Hello, my name is Paul Wischmeyer, and I'm a professor of anesthesiology and surgery at Duke University Hospital, where I also serve as the director of the nutrition and TPN team. And I'm excited to talk to you today about, get my slides going here, nutrition and exercise and how they go hand in hand, even in the ICU. And I want to review the current knowledge we have around this. So again, these are briefly what I'd like to call my alignments of interest or my conflicts of interest. And I think, as I've said before, the key piece that I want to convey is we must take responsibility, not just for the outcomes that occur in the ICU, but also what happens after the ICU. And so that is every day as we're on rounds, we're always thinking about what are the things we need to do today to not only ensure what we need to do to have the patient survive and recover from the acute illness, but recover their quality of life afterwards as well. And are there exercise, nutrition, and other care therapies that we need to be being sure our patients are receiving? Because again, our goal is ultimately to create survivors of our patients to go back to their families and not victims that perhaps never go back to a meaningful quality of life or remain in rehabilitation facilities for the remainder of their lives and never go back to walking down the street with the people they love again or holding their grandchildren, which is what they came to us to give back to them in the first place. Because the reality is surviving and recovering from the ICU is often the marathon of many patients' lives or of almost every patient's life. It is the ultimate marathon of their lives. And what happens when we ask our patients to run the marathon of their lives without the right training in nutrition, perhaps both before and after the ICU stay? And so perhaps this is the marathon to table or the marathon to ICU, we call it. And I have to thank Yaron Mullinger and John Whittle for this wonderful way of thinking about it. And to describe that, I want to tell you about a patient that we cared for not so long ago and have become quite close to his family. His name was Elijah, and he was an 89-year-old who came to us for partial colectomy for rectal cancer. And he'd lost about 10 kilos of weight over the last 3 months prior to his operation due to his cancer. And he definitely said, "I feel weaker than I used to." But this was a very active individual at 89. He was on the ladder fixing his church roof at home the day before his surgery, before his surgery occurred. And then he said to us as he went to surgery, "I can't wait to travel to see my new granddaughter after his operation. I want to be well enough to see her and watch her grow up." And the one question is he ready for surgery, which is a prehabilitation question beyond the ICU. But the reality is he went to surgery and he probably wasn't ready. We're trying to find better ways to optimize patients, but he went to surgery, did okay for a few days, but on post-op day 3 had acute abdominal pain, rectal bleeding, and acute decompensation. He went to the OR and on his way to the OR, of course, he had a CT scan and he was shown to have ischemic bowel. He developed hypovolemic shock. And in fact, while in the OR, he had a brief cardiac arrest with 1 round of CPR. And I remember this is an 89-year-old. And so they found an anastomotic leak and then also ischemic bowel. And so he came back to the ICU with an open abdomen, very weak, on the ventilator. And of course, he's already got malnutrition from his prolonged weight loss and lack of nutrition. And so the real question that came up on rounds was, can he survive this? And probably appropriately so, people on rounds began to ask, he's too old and too sick to recover from this. Perhaps we should talk to the family about withdrawing care. And sometimes I think that is the appropriate decision. But I can tell you that many of us as physicians, both the surgeon and myself, having gotten to know the family, said, no, I don't think this is what they want. I think they want us to fight for this patient. That didn't seem to be his wishes. And so he gets his abdomen closed. He's extubated now day 3, and the family and the patient agree they want to keep fighting, that they are not ready to give up. They said he wants to go back to his church. He wants to go back to seeing his granddaughter. And he was very active before. We think he can get through this, and he thought he could get through this. So we all agreed our team would fight for him. And the question is, can we save this patient and give him his life back? And what do we need to do that? Because I think to save patients like this and to save all our ICU patients, we need to continue to do better for their ICU recovery, or as Jackie Shanisha said, for their ICU survivorship. And how can we do that? And I think it's going to take a combination of nutrition, therapeutic nutrition, targeted nutrition, good physical therapy and rehabilitation, and then perhaps some learnings from elite athletes and how they train and how they optimize training. So what are our exercise and nutrition goals to prepare and recover an ICU patient? Well, clearly we need to recover muscle mass and we need to recover, aerobic fitness. And so again, this needs to be a personalized recovery plan, giving the right nutrition and exercise dose to the right patient at the right time. And we need to be measuring. We can't just say go and exercise or go and eat. That is not going to work. So if we're going to measure things, what were this patient's muscle and body composition measurements in the ICU? So in the last lecture, you heard me talk about the devices we're using at Duke to measure these patients. This is the BIA measurements. Again, he had a very high body fat mass, very low skeletal muscle mass, and very low muscle mass by ultrasound with poor muscle quality. So we had a lot of work to do, but we had a starting place. We knew there were measurements, we knew where we were starting, and so we knew how to objectively follow on a week-to-week basis our progress. And so starting with his nutritional needs, of course, protein is essential to recovery. You can't build a house without bricks, and you can't rebuild lean body mass or muscle mass without protein. And this is an outstanding paper from Peter Weiss and Stuart Phillips, who's a real expert in the muscle field and the nutrition muscle field, really somebody I look up to, published in Current Opinion, that really shows us the idea of anabolic resistance. You know, as we age, it takes more grams of protein to gain the same amount of muscle as it did when we were young. And so not everyone who ages loses muscle. This individual's maintained a lot of muscle mass at age 70, and that is not just eating well that does that or exercise. But we can learn a lot from these athletes. They take in a lot of protein. They take in boluses of protein, not continuous. And Zuden and Puducherry's Danny Bear has done some research now in bolus feeding, and I think it's got a place. Then they give themselves a lot of leucine and HMB and other essential amino acids, often taking in a large amount before they go to bed when they're anabolic. And then it has to be combined with exercise and strength training, because the anabolic resistance of critical illness is quite a bit more severe, and it takes much more protein to gain muscle, and likely it's going to take other anabolic agents and substrates like HMB, oxandrolone, and anti-catabolics like propranolol to recover. We'll talk a little bit about that later. But what are we feeding patients now, and are we giving them at least the base requirements they need to begin to recover before we add exercise and anabolic agents, perhaps, to those things in rehab? Well, we know, of course, from Darren Hyland's data that we don't feed our patients adequately, especially in the US. We underfeed for 2 weeks. We give our patients half of the nutrition they need, not for a day or two, but for weeks. And so it's no wonder it's very difficult to recover. And our protein delivery is even worse. We give a third of the protein we say our patients need, a half to a third, for not a day or two, but 4 weeks in the ICU, which without the fundamental building blocks of muscle, it's going to be virtually impossible for our patients to recover. And so this is really, I think, a contributor. And so if we're going to create survivors, can improving nutrition and protein delivery help? Can it help patients gain muscle? Well, there's some hints at this data from the early PN trials done in Australia by the ANZIX group that showed that early parenteral nutrition and protein delivery reduced muscle wasting in the patients that got the early PN. So here's some signals of reduced muscle wasting with better amino acid and protein delivery. This was data from the Redox trial that Darren Hyland and I did. And this was the subgroup that were on the ventilator more than 8 days. And his group was able to show that patients who got more than 80% of calories and protein had the highest survival. But more importantly, we had SF36 scores on these patients out to 3 and 6 months. And for every 25% increase in nutritional delivery over the first 8 days, these patients had significant, clinically meaningful changes in their physical function by SF36 after ICU. And so again, we can make a difference in what happens to our patients with how we feed them in the first week or two of ICU, perhaps months or even years later. And so again, this affects what happens to them, this data would show. Now, especially in COVID patients, but as I showed you in all ICU patients, getting to goal enteral nutrition is very difficult. And there's a lot of GI tract involvement in COVID-19. And so the question is, should we be starting parenteral nutrition sooner, especially in those that are malnourished or that we expect a longer MPO period in? And that brings up the question is, does TPN and parenteral nutrition increase the risk of infection in ICU patients? And I'm curious what all of you think as you listen. I hope you answer this correctly. The answer is clearly no. There are now 4 large randomized trials of many, many patients in journals you've heard of, New England Journal, Lancet, and JAMA, that show it has no association to infection risk in 2020. It is just as safe to put TPN through a line as it is to put saline through a central line in modern ICU practice. And I can't stress that enough. Why is that? It's different from what you're probably taught in medical school or in other training. TPN is no longer related to infection because we don't hyperalimitate anymore. We don't give 35 kcals per kilo on day 1. We control hyperglycemia. Most of the infection-related morbidity from TPN was done in studies before glucoses were treated. We didn't use glucoses over 300 when I was a resident. That wasn't that long ago. We have better protein delivery, we have better central line care with our checklists, and we have better lipids. We now in the US have fish oil and olive oil-based lipids. If your hospital's not using one, change it now. It is one of the best things you can do for your patient. The meta-analysis data clearly shows reduction in infections everyone should be getting a new lipid and no one should be getting the routines interlipid omega-6 lipids. So what about our patient? He's starting to recover, and will he eat enough on his own? Not likely. We know that the average intake of a post-ICU patient is about 700 kcals per day, which I can tell you is not nearly enough. So we're going to need to use oral nutrition supplements, and we did in this patient to get to post-ICU needs. We know there's a lot of data to show they reduce mortality, they reduce complications. Every dollar you spend on these little nutrition drinks reduces costs or saves hospital costs quite significantly for our patients. And in fact, that number comes to, hold on, let me get my cursor back. What's happening here? It saves, for every dollar we spend on OS, we save $52 in hospital costs. Sorry, I lost my cursor for a moment. And there's now a large randomized trial of hard protein HMB containing oral nutrition supplement that shows a significant reduction in mortality at 90 days post-hospitalization. So now we have large randomized controlled trial data showing improved outcomes, and this showed improved muscle strength as well. And so I think the post-op use and the post-ICU use, of oral nutrition supplements is essential to recovery. But is the right nutrition enough to win the war? Is nutrition alone going to do it? And the answer clearly we believe is no. Calorie delivery alone won't stop lean body mass loss. Giving enough nutrition will slow it. And I think that's the baseline we all have to achieve. We have to give good basic nutrition if we want any of our other exercise or anabolic interventions to work. But by itself, we all know it's not going to do. You can't eat your way to being fit and to gaining muscle by itself. And again, we're not evolved to survive these kinds of injuries. Our body doesn't know when to turn off the catabolic signal. Hypermetabolism and catabolism can persist for months to years after ICU stay. A burned child will remain catabolic for 2 years after an ICU stay. And so this can be quite dramatic. So is there things we can learn from elite athletes to help our patients? And I think there are. And I think taking the right anabolic agents can help. And so I think we need to find ways to consider that as part of our care. And one of those agents is testosterone. And again, this shouldn't be given in the acute phase or the first few days of ICU, but the post-acute phase data for this is much more promising. So again, testosterone levels in the ICU drop dramatically. And so I check them often. And almost everyone I check is severely deficient or even zero within 3 to 5 days. And this has been published. I'm not the first to show this by any means. We know that within 3 to 5 days, everyone's testosterone level is exceedingly low. And when this has been given back using oxandrolone in burn injured patients, we've seen dramatic improvements in survival and reductions in time of wound healing and numbers of surgeries. There's lots of positive data, and also for functional recovery in burn patients. So this is widely used and standard of care in burn centers around the world, even in third world countries, South Africa, India, and other places. But is it safe? You always are going to get asked the question, is it safe? Does it increase cardiovascular risk? Is it going to be okay for my patients? Well, the answer is it does not increase cardiovascular risk, and it is very safe, and in fact reduces cardiovascular risk. And I can't say that strongly enough. Testosterone supplementation in deficient patients reduces cardiovascular risk. This is one of the many studies that show that. This is 43,000 subjects studied in the Kaiser studies, in the Kaiser healthcare system. All testosterone deficient, randomized, or it was an observational study, receiving either testosterone replacement or not in an observational way. And the patients who received testosterone replacement had significant reductions in combined cardiovascular events, stroke events, and cardiovascular alone events by 30%, by a third on average. So significant reductions in cardiovascular adverse outcomes. Intermountain Health has shown the same data, even in patients with coronary artery disease. They showed reduced risk of cardiovascular events and stroke events in these populations. So this protects you, actually, it looks like, when you were repleting people who are low. So again, I think a total testosterone is fine. You don't need to check a total and a free. It costs more. Total testosterones come back very quickly. 94% of patients when this is studied are severely deficient by day 3. These are the doses you can use. Oxandrolone 10 milligrams POBID is perhaps the best. It's purely anabolic and can be given orally, which is really a plus. Testosterone cypionate is the standard. There should be an R in there. Testosterone cypionate is the standard 200 milligrams IMQ 2 weeks. That's been used for many, many years in the outpatient setting. And then you need to ensure adequate nutrition, or this is not going to work. This is a recent publication that myself and Rosemary Kozar and others, Steve Wolf, have put out, and we cover the different testosterone agents and how to think about using them and sort of how they're used in other settings with references for all of this if you want to learn more about this. And this was the sort of etiology and treatment for the post-ICU physical disability that we proposed, that clearly all the factors that ICU brings upon the patient lead to catabolism and muscle weakness. And this leads to physical dysfunction that we must address. And so again, we need therapy, structured exercise, physical therapy, we need anabolic agents, and we need protein. We need all three to recover our patients. And so I think this is our best chance, this triad of recovery interventions to improve outcomes. So again, this is the patient we want to get. We want to get a patient back to their exercise, back to their quality of life. And what role does exercise play in all of this? Well, there are already studies combining exercise and nutrition. This is the Nexus trial, some of you may have heard of. This is Darren Hyland and Dale Needham and Renee Stapleton. And it's a multi-center trial looking at in-bed ergometry with amino acid IV supplementation. And it's ongoing at multiple sites across the US. So it's funded by NHLBI. And Clark Files, I have to thank he and Dale for this slide and information. They're doing also some mechanistic trials, looking at muscle biopsies and other mechanistic outcomes. So this is a really exciting trial. It has a great paper if you want to read about how they designed this trial right there. Now, this has actually been looked at in a neuro-ICU population in a pilot study looking at neuromuscular electrical stimulation, and cycling, and looking at high protein supplementation. So electrical stimulation and high protein supplementation, and the patients who got the neuromuscular electrical stimulation and high protein had improvements at post-stroke day 90 or post-bleed day 90 on the SBBP, which is a standard physical function test in the modified Rankin scale. And they also had less muscle atrophy, right? For muscle to grow and to maintain muscle size, you have to have contraction. You can't just passively be cycling. You need contraction and motion to optimally grow muscle. And that's why contraction is so important. And that's what electrical stimulation does. So this is a nice paper that Dale Needham shared with me. So again, this appears to be feasible and safe in post-stroke patients and may reduce muscle wasting and have some benefits long-term for our patients. So again, combination of protein and neuromuscular stimulation. So this is another great concept paper for those of you interested in this topic that Darren Hyland put out. This was in the preparation for the Nexus trial. And then in terms of how you look at outcomes for these trials, the NIH has funded Dale Needham and his group to create an outstanding improve LTO, improve long-term outcomes core set that we all should be using in our research for our patients. And so I encourage you to join this website. It's free, and see all the amazing work that Dale and his group have done to help us think about how to measure and do studies in this area. So, but can we learn from elite athletes to take this to the next level? If someone was training for the Olympics or for a marathon, they would do things that we aren't doing for our ICU patients, but that could perhaps benefit them a great deal. And it doesn't involve sitting on a cycling recumbent bike like this. It involves getting tested and studied like this. And this is cardiopulmonary exercise testing that we're doing at Duke, and lots of other centers around the world are doing as well. And it measures all kinds of exciting things. And it really gives us a lot of information, VO2 max, anaerobic threshold, and it lets us target exercise in a way I'm going to show you. And it teaches us about how patients are metabolizing and how their mitochondria are functioning. Why is this so important? Well, let me tell you about another patient. This was a burn patient I cared for a number of years ago. His name was Joshua. He's an amateur athlete in Colorado, had a full thickness burn, 37%. He got better very quickly, was only in the hospital 24 days, so less than we would expect. And he went back to his life, and a few months later tried to start cycling and riding his bike even again and exercising. And he had incredible difficulty. He couldn't even ride up a hill outside his house without having fatigue and having to walk his bike. He couldn't ride for more than 5 minutes. And he was stunned by this, and he tried and tried and tried to improve without success. So he came to Colorado and underwent an exercise test with Inigo San Millán, one of our real elite. He was a Garmin Tour de France coach, CPET testing expert. And what CPET testing can tell you about is you can actually look at substrate utilization. And again, remember, fatty acids can only be used in the mitochondria, where glucose and carbohydrates can be used in the cytoplasm. So you can learn a lot about mitochondrial function from this testing. This is what a world-class athlete looks like on this testing. They can use fat, as you can see in that red line, out to very high workloads. And they'll maintain the ability to use fat and only shift to carbohydrate oxidation at very, very high workloads as they get to max effort. So they have a very high mitochondrial density and ability to use lactate and fat very efficiently. This is what an obese diabetic patient looks like when they're tested. They have a very poor fat utilization. Only at very low workloads can they use fat, which is why it's hard for them to exercise at much intensity for any length of time. And they quickly increase their carbohydrate utilization and their lactate generation. So again, this patient who's unable to bike up even a hill 6 months after they leave the hospital, what was his data on CPET testing? So you can see he could use no fat utilization at any workload, even very low workloads. Inigo San Millán had tested 10,000 people at this point. He's never seen a patient like this, but he'd never tested an ICU patient. And so no fat oxidation at all at any workload, only carbohydrates. His mitochondria will not function in any way, shape, or form. We retested him twice, trying to show this was true, and we saw the same result a few weeks later. So again, no mitochondrial function. And so he was placed on a heart rate specific HIIT training program using nutrition and exercise, which we'll talk more about. And a few months later in October, his fat oxidation returned. We were able to rehabilitate his mitochondria using HIIT training and return to fat oxidation in this patient. And he was able to recover this, where before he was not able to use it at all. So this was, again, treating the mitochondrial dysfunction of critical illness with targeted training. He's now a competitive cyclist competing 160 kilometer bike races. He got his life back, but it took this kind of testing to target our care. And so how many of our patients will continue to suffer from the post-exercise and post-ICU exercise dysfunction and never walk or even run or bike again? So personalized exercise and nutrition training is becoming a reality. We can do this. The future is now. We're doing it at Duke. We're planning it for trials. And here's some personalized prehabilitation data that we want to show you. This is John Whittle and Jeroen Mullinger again, who you've heard me talk about. This was a trial to optimize very large, high-risk surgical patients before surgery using this technique. This is one of the patients we optimized, Michelle, who's coming for bladder cancer for cystectomy. She was very debilitated, was on oxygen and using a walker. When she came to us, we put her into a 4-week high-intensity training protocol basing her heart rate targets and her goals 3 times a week at home on her CPET testing. So we structured and targeted or personalized her exercise based on her first CPET. And then she came in 3 times a week to an outpatient rehab center and did these with a little card you put in the bike that took her through an exercise routine, a HIIT routine. And so there's a protocol for this that Mike Rocott and Denny and his wife in England have developed. We used that. We included high protein ONS with HMB after training and in the morning on training days and then twice a day otherwise during the week. And you can see that she started out with a fairly high body fat mass and a fairly low leg lean mass. And in 4 weeks, just under 4 weeks, we reduced her body fat significantly and we increased her lean leg mass by almost 2 kilos, by over a kilo. And we did this in a very short period of time in a very debilitated patient. And we increased her VO2 max and her MET significantly. You can see we increased her VO2 max by about 200 plus, 250 plus, and we increased her METs by over 1. So again, a VO2 peak by a whole measured exercise unit increase. So that is equal to a 15% reduction in mortality risk lifetime if she can maintain it. So this is a big effect in a very short period of time. We're taking this to the next level, we hope, with a post-COVID study where we're going to do CPETs at discharge of COVID ICU patients and then put them on a home monitored using iPhones and iWatches in high intensity training program. They do 3 times a week, monitored by a physical therapist in their homes. We are grateful to have received the 2021 Discovery Award from the Society of Critical Care Medicine for a grant that we submitted, both myself and Wes Ely submitted, and we're gonna be training a really exciting young person, Matthew March, who's a new attending at Vanderbilt, who's very interested in this, and we're gonna look at cognition and physical function looking at this, and we hope to submit to the NIH as well. This is again, we're going to do face mask portable CPAT testing, which is now available. We're going to buy instruments for all the centers, and they do a step test in their hospital room before discharge. And then they go home with an iPhone and an iWatch, and they do sessions 3 times a week for 3 months. And this actually was developed by a cancer physician, a BMT physician at Duke, Tony Sung. And we have preliminary data in debilitated cancer patients that shows incredible adherence and compliance with these sessions and a 25% increase in VO2 by 4 weeks. So you can see the patients have a target zone in green, and we monitor them beat to beat with the iPhone and the iWatches, and we actually can coach them on the best ways to do this. They do this through stepping, they do this through walking, they can do it through cycling if they want, but they're monitored and doing this. We've had incredible adherence and compliance with this. And so this is the plan. We're gonna go back to that. We're going to do a structured plan where we follow these patients out to 3 months, and we're going to bring them back and do CPET testing and measure and do 6-minute walk testing and do measurements both at hospital discharge in 3 months following that. And so if you want to read more about this, these are some of the recent papers we've published on combining nutrition and exercise and some of these novel interventions, including anabolic agents. I'm happy to share these articles with you by email. But in the end, what did it do for our patient we've been talking about, Elijah? So again, we've kept fighting for this patient, and what do we do to help this really, really aged patient who really was desperate to recover? So we put him on the high protein ONS with HMB, 2 grams per kilo per day of protein. He was on TPN for a short time. We started testosterone cypionate. We started creatine for this patient. We replaced his vitamin D that was quite low. And then he started very aggressive exercise and recovery, doing walking and chair sit to stands. His family brought in their own dumbbell weights. He had exercise bands in the bed, and he aggressively combined all of these interventions and walked out of the hospital 28 days later on his 90th birthday. So the patient was committed. We were committed. We did structured exercise for him. We did structured nutrition for him. We made measurements, and he left the hospital, which many people said there was no way we'd ever get him well. But it is possible. This is actually him. He gave me permission to use this picture. He lived for another 1.5 years. Ultimately was able to see his family, was able to spend time with his family, and they were all incredibly grateful for the almost another 1.5 years, over 1.5 years that he got to spend with his family. So this was really a gratifying save. So in the end, we must train our ICU patients for recovery, because this is the marathon of their lives. And that change needs to start with us. I think we need to be good examples for our patients. Because in the end, as I've said before, we need to be creating survivors of our patients and not victims. And we need to do better than we're doing and use all this opportunity, all this new technology to prescribe the right nutrition and exercise doses in the right patient at the right time and be able to measure it, which we can do. And these are all the new technologies that are available to all of us, I think, very soon. I think all these things are things we can be doing, and all of the different other interventions that are possible. Again, this is the nutrition delivery that we're suggesting. And feel free to ask for this. I'm happy to send you this slide and this picture. And then, of course, exercise, in addition to nutrition, is essential, and it's something we all struggle with in the US and around the world. But I think this is something that just shows us we can all be better. This next video is from a very small third world ICU in the rainforest of Brazil. This is a patient doing bed squats on the ventilator in a government hospital that doesn't have near the resources most of our academic hospitals do. So if they can do it, we can do it. And then I think the other thing that we all hope to dream to have is these exercise weight training beds to increase strength, where you can do squats right in the bed. And these devices are actually available commercially. I dream of us getting one soon. So again, I hope we can take patients using all these technologies, combining nutrition and exercise, to have them, again, be walking very soon, and then actually save some lives and give back quality of life to patients like Elijah, and have them leave the hospital looking like this, or at least like this. So again, thanks for your attention. Feel free to follow on Twitter and Instagram for more of this research and more findings that we share all the time in our data. And feel free to email me for any of these papers, or emailing me any questions at any time. Thanks for your attention, and enjoy the rest of SCCM. Take care.